really amazing to see so many young people in the audience. It's not too long ago I was in your shoes, quite literally. I used to live at 1233 York Avenue, which is literally across the street, for 4 years, and I saw this dome every day, and I'd never been in it. So it's pretty cool that I'm in the dome. So I am, my background, so I'm a physician. I'm a geriatrician and a cardiologist, and I never thought I'd work actually in the private sector. I was a academic researcher on NIH grants. I used to build quality measures for the government, for CMS, Medicare. And growing up as a physician in a hospital, your worldview is often limited by the hospital. It is what you see every day. It's where the medical school is. But there's actually an amazing world out there in the private sector where innovation often moves much more quickly, which was part of the reason I moved, even though I was very happy within academia, to the private sector. So real quick about Clover, because I'm not really actually going to talk about Clover, just for context. Clover is a Medicare Advantage company, so we are a health insurer in the Medicare space. We have about 50,000 older adults, and some who are younger, who've bought into Medicare or have Medicare benefits early because of disability. We have about 50,000 members across 6 states, and we're growing. And we're also a technology company. We invest a lot in technology point-of-care tools. Happy to talk about that more, but that's really not what I'm going to actually talk about today. What I'm going to talk about today, actually, is a real movement we're seeing within the healthcare space to go back to the home, right? The home really is where the health is in many respects. It's where the heart is, but it's where the health is as well. This is actually a very iconic image of a house calls provider. It's from the 1940s. It was in a Life magazine spread. Dr. Ernest Sirianni, and that spread really, I think, emphasized, humanism, determination, as well as exhaustion. He was a rural physician, and he did house calls. And really, that was very prevalent in the 19th century, the early to mid 20th century, but by late 20th century, it had largely gone away. And who thinks that happened because patients became less needy, that there was no medical need out there? No, that's good. And let's see if I can advance this. Perfect. So obviously not, right? So demographics matter, right? Population is aging, not just getting older, but there's more older old Americans, middle-aged old, and just folks who are over 65, and that's clear. And with aging comes disability. It becomes harder for folks to leave the home. And with aging also comes chronic disease, and this is essentially a paper showing that the growth in chronic disease, whether it's diabetes, high blood pressure, stroke, et cetera, it's just increasing over time, right? So medical need has been present. It's actually increasing over time. So it's not like people can benefit from care being delivered to them. What else do people think? Let's be a little bit interactive here. So it's not about patients' needs. What else could have been a blocker to house calls practice? Anyone? Expense. So the economics matter, right? So this is just my way of describing what house calls providers go through, right? So they have to either drive there or walk there. They have to take, and I do a little bit of house calls for Clover, right? So I've seen this firsthand. They have to get into buildings. They have to climb walk-ups, right, to the 10th, 12th stories. They deal with weather, traffic, all sorts of things, bugs just being one of them that you see in people's homes. And that hasn't actually translated to the economics of it, right? So when physicians code for reimbursement, there's something called E&M codes, right? So a level 5 E&M code, which is for a complex patient in an office through Medicare, will pay about $100 based on the most recent fee schedule. A home visit code, most of whom are complex patients, could be $130 to $160. But think about how many patients can be seen in a doctor's office. A well-functioning office, even though this might not be the best care, it can see, a provider can see 30 to 40 patients in a day. A well-functioning house calls provider might see 6 to 8, right? So if there's a 30% increase in payment, but 25% of the patient volume, I think the economics actually should be clear to you why it just couldn't work out in many cases. So I think, we're talking about the future of healthcare, right? So there are a few lessons I want you to take from this. One is demographics matter, demography matters, right? Which was the slide about aging. The second is that there needs to be alignment in a lot of different entities, right? So there has to be a need for the patient. Providers have to see a need, right? When we've heard that, right, from the two presentations to date, whether it's about hearing aids, audiology, new technology tools for use in interventional procedures, but there's a payer side to it as well, right? And so I sit now on the payer side, and a lot of the pitches we get are folks who see a patient need, but there's real poor integration with the provider, or there's not really a concept of, frankly, why would a payer care, right? How would a payer integrate this? And at the end of the day, the dollars flow from the payer, whether that's CMS in Medicare for fee-for-service Medicare, whether that's a Medicare Advantage company, right, an insurer in the Medicare space, whether that's commercial insurance, meaning the insurance you get, if you're employed currently, in most cases through your provider, whether that's Medicaid, there has to be alignment here. So I think this is a really important lesson for you to take away, because I know there are a lot of entrepreneurs here, folks thinking about how to build something new that solves the need for a patient, but think about this alignment, because if you don't, you might be in for some nasty surprises at the back end. So where has the alignment actually gone over time? Because you're actually seeing house calls come back. I think the biggest driver you're seeing, at least in Medicare, is the proliferation of Medicare Advantage. Some of you folks probably know what Medicare Advantage is, many of you don't. So when you're an older adult, predominantly, or you're a younger person with disability who has access to Medicare benefits, you essentially have an initial fork in the road. Do you elect to go with traditional Medicare, right, which about 2/3 of older adults do? That's the Medicare where essentially Medicare covers 80% of costs. I mean, it's more complicated than that, and you're responsible for the remaining 20%. There's often no cap on out-of-pocket costs. And sometimes people buy what are called these Medigap or supplemental policies to address that 20%. The remaining third of folks choose to get Medicare through a health insurer, and you've heard of some of these insurers: United Healthcare, Aetna, Cigna, Humana, Blue Cross Blue Shield, et cetera, et cetera. And in that 2/3, the key thing I want you to remember is that is rising. The 1/3 in Medicare Advantage. The proportion of older adults who are electing for Medicare Advantage is going up and up and up and up over time. In the early 2000s, there was only about 5 million older adults who elected for it. And by 2026, the thought is that there was going to be closer to 30 million, right? So 20%, 25%, 30%, 35%, 40% of older adults. And there are a number of reasons for that. Older adults through Medicare Advantage often get more benefits. Some Medicare Advantage plans cover hearing aids, audiology, services, dental care, glasses, fitness benefits. And it's a real place of innovation. So as you're thinking about where your careers may take you, the government's actually offering a lot more flexibility to Medicare Advantage plans through what are called supplemental benefits to drive innovation. And so Medicare Advantage plans have a lot of incentive to control costs. And there's this sort of common population health idea that there's about 5% of members for these plans or patients that are responsible for 40, 45, 50% of costs. So there's a lot of leverage for these companies in helping keep that 5% healthier. And house calls has been really a big part of that strategy. So Independence at Home was maybe the most successful medication demonstration project ever, which essentially found that older adults with functional needs and chronic health conditions that resulted in hospitalization, if they were engaged by house call teams in their homes, they lowered medical expenses very significantly and improved outcomes. And you see a lot of the same trends happening in the private sector, right? Landmark Health, so the Medicare Innovation Center was formerly led by Adam Bowler, who ran Landmark Health, which is essentially house calls, Humana, Payer, CareMore, Payer, Clover, where I am, Cricket, and the list goes on and on and on, have begun to show real savings and outcomes improvements by engaging people in their homes. And it's actually not really surprising when you see it. If you go into someone's home, in many cases, these are just a few of the things you see, right? The meds are all screwed up. People struggle in many ways, whether it's food insecurity, clutter that results in falls. They have a blood pressure cuff, but they actually do not know how to use it. It's sitting in a box, and you don't know that until you go into their home, right? So there are a lot of obvious reasons why the home is a great place to engage with a patient. I can think about a patient I saw a few weeks ago. She was blind, or is blind, and she had 6 different insulin formulations in her home, right? This is not crazy. I had one other patient in the past who literally had a candy bowl filled with meds. And she said, I actually don't know which ones I'm supposed to take on a given basis. It's too complicated for me. So I just literally reach into the bowl every day, and whatever comes in my hand is what I take that day. And these are real stories. And in the office, you don't see any of that, right? I think as you think about a challenge, though, as more and more you see this engagement in the home, on that provider side, it's not a surprise to many people, there is a real shortage of primary care physicians. And that shortage is actually going to increase as you think left to right over time as we age and population needs increase. And so I think one of the challenges for people like you who are thinking about doing something entrepreneurial is if you want to engage in the home, and there's a real provider shortage that's going to get worse over time, how can we use technology to really leverage, scale? And you see some of that now through telehealth, through use of other folks besides physicians, whether they're nurses, social workers, et cetera, to really drive some of the same outcomes improvements that are so important for our older adults and the Medicare program and healthcare costs in general. So I'm just going to leave it at that. Happy to answer any questions about Clover, trends over time, and thanks for having me.
Future of Care is New York City's premier community for healthcare innovation. To learn more, subscribe to our channel and visit our website at futureofcare.nyc.